efficiency, and administrative excellence. Over the years, he has made significant contribution to the field of preventive medicine, public health, medical education. Through his teaching, research, and administrative leadership, he has played an important role in strengthening the quality education and promoting the advancement of Ayurveda at national level. We are indeed honored to have such an accomplished scholar and inspiring leader with us today. On behalf of everyone, I extend a heartfelt welcome to Dr. Shivakumar SRT and invite him to address the gathering. Thank you, sir.
Thank you, sir. A warm welcome to Dr. Supaharti, sir. Sir, kindly share your PPT and kindly start your valuable lecture.
Okay, thank you, sir. Thank you, Kiran, sir. I hope the PPT is visible.
Yes, sir.
Yes, sir.
Respected NCSM Chairman, Madam, President Board of Ayurveda, Dalapurba Buddha, sir, and all the members of senior respected members of NCSM, the moderators and the architects of this Pragati Faculty Development Program. A warm very good afternoon, everyone. So, in my session today, we will be discussing on the strategies for effective implementation of practical training and experiential learning. Dear colleagues, we know that we have always been taken pride in preserving and transmitting the wisdom of our classical text. However, today's challenge it's somewhat different. Our responsibility is no longer confined to producing a graduates who know Ayurveda. We must produce a graduates who can practice Ayurveda safely, independently, and compassionately. So this is the essence of competency-based medical education. Now, today we are talking about pedagogy. Many teachers believe that pedagogy is just learning how to teach. But in reality, pedagogy encompasses various other things. It includes curriculum planning, it includes learning objectives, teaching strategies, clinical exposure, assessment, feedback, reflection. So, pedagogy is a complete science of learning. In Ayurveda, teaching has always been an holistic. Our gurus didn't merely transmit the knowledge. They also cultivated judgment, discipline, ethics, observation, and compassion. Competence-based education, in many ways, a modern articulation of this traditional education principle. So we are not deviating anything from Ayurveda teaching principles. We are rooting back to Ayurveda teaching principles. Right? And sorry, why is the change needed now? Today, patients expect evidence-based decisions, communication, empathy, safety, and professionalism. And that is why NCSM has come up with a syllabus or a curriculum where it has shifted emphasis from what the students know to what the students can do independently. So this aligns with the global competency-based medical education adopted by various medical councils of worldwide already. If we see it to Charaka Samhita also, there the guru or a teacher did not merely test a memory. If we look at a various contexts in the Samhitas, student demonstrated, they observed, they gave a reasoning, right? And they also had a patient examination, drug identification, therapeutic judgment. So knowledge without application was never considered sufficient. If we take an example, like we have two students, one is student A and student B, and if a student A can explain Staulya according to Charaka each and every shloka, whereas a student B, he can interview the patient, he can identify the nidanas, he can assess the agni, he can explain the patya, he can motivate the lifestyle modification, he can motivate to have a life modification and follows the patient for 6 months. If you consider these two students, the later one, student B, is better because he is more competent. So teaching knowledge creates scholars, whereas teaching competency, it creates physicians. And that is why the thing comes is that if competency is our destination, how do we design our teaching journey? Right? So transitioning from passive delivery to a clinical autonomy. For decades, our classroom functioned remarkably well in transmitting information. However, transmitting information is not synonymous with creating competence. So if we look at a traditional didactic model, usually the teacher speaks, students listen, students memorize, students reproduce, and examinations recall. But the problem with traditional medicine is that, traditional model is that it is knowledge overloaded, passive learners, limited questioning, minimal reflection, skills remain fragmented. If students usually will ask, will this come for the exam? Instead of, will this help my patient? So this is a problem. And that is why a new framework which has been designed by NCSM, it is more learner-centered education. Instead of information delivery, it facilitates learning experiences. Students observe, students perform, students reflect, they receive a feedback, repeat and improve. So learning becomes cyclical rather than a linear one. And clinical autonomy doesn't mean that students are allowed to practice unsupervised. Rather, it means that progressively entrusting them with responsibility. Initially, they observe, then assist, and then they perform under supervision. They perform independently later on. So this gradual progression is fundamental to a competency-based education. I am from the field of Swastavrata, so most of my examples in this presentation will be Swastavrata. That can be applied to any other stream also. So competency is not memory. Competency is a reliable clinical performance, right? So if learning must change, the learner also changes. That brings us to adult learning principles. So grounding pedagogy in adult learning principles. Our postgraduate students are no longer children. They are adult learners. They learn differently. The first principle is that, adults need to know why. Before learning, they ask, why is this important? Instead of beginning with, for example, if I take that today, we'll discuss the Shoka Dhanyas, right? So it is better that start with giving them a problem statement. Like a diabetic patients ask whether rice is completely prohibited. So immediately this increases or triggers a question in a student. And most important is that these adults or postgraduates, they already have a clinical exposure. They have done their internship, they have their own personal observations, and it is our responsibility to build their knowledge, build upon these own experiences. And learning must solve problems. Adults dislike memorization without application. Today, when you ask a postgraduate to memorize a shloka, they don't like it. But if a graduate one, it is fine. So they need a clinical scenarios. Instead of asking what are the properties of some dravya, we can ask them that which drug or which grain can be recommended in a diabetic laborer who can't afford millets. Now that becomes more practical. So simply, we can give them a prameha scenario where instead of directly dictating in the dietary advice, student can be motivated, or a student can given a task of taking dietary history, assessing Agni, identifying the cultural food habits, understanding affordability, and design an individualized diet chart. So this is personalized. And Ayurveda always has emphasizes Desha, Kala, Prakriti, Vaya, Agni, etc. Therefore, uh, teaching should also not be standardized. Adults learn best when teaching begins with authentic clinical problems. So if adults learn differently, naturally, we can't teach every learning outcome using the same teaching methodology, right? So we have different teaching methodologies. There is a universally best teaching method. There is only most appropriate teaching method for a specific learning outcome. For example, we go to level 1. If it is a knowledge, lecture works well. Students need conceptual foundations. For level 2, understanding, discussion, clarification, and concept mapping. Right? Level 3, clinical reasoning. We have a case-based learning, and students integrate here multiple concepts. Fourth level, if it is a problem solving, then problem-based learning is the best methodology. Student investigate here, right? The unknowns independently, the unknown variables independently. Level 5, communication. If it is a communication is a outcome, then role plays, simulation, mock counseling. These are the best teaching methodologies. Then for a skills, practical training. repeated supervised performance. So this is running. And if you want to build up a competency, then experiential learning, real patient responsibility, reflection, feedback, longitudinal follow-up. So these are all very much essential. For example, if you teach a yoga lecture, we can teach that the benefits of Surya Namaskara. Practically, we can show them how Surya Namaskar be done. But experiential is conducting a yoga session for a diabetic patient, modifying postures for elderly participants, monitoring their outcomes, and reflecting on effectiveness. So only the final stage develops competency. So can communication skills be taught through lectures? No. Exactly. So methods must match the outcome. So we have 7 levels. Whatever the outcome, the respective methodology should be used. So we should not choose the teaching methods because we are familiar with them. Teaching methods should be chosen because they develop an intended competency. Among all these methods, the two are most common confused: practical training and experiential learning. We'll have this in the next slide. So the core shift: practical training versus experiential learning. This discussion is the most important message of today's session. Now, the practical training, the purpose is to teach the students how to perform a task correctly. And this can be done in a laboratory, classroom, or a simulation. Here, faculty supervises each and every step, and the outcome is skill acquisition. The students will come up with they will have a skill. For example, preparing a diet chart, performing a NADI examination, or preparing a Panchakarma Aushadhara Basti Dravyas, etc. in a Panchakarma Beshajagaras. Similarly, if we look into experiential learning, the purpose is to develop a judgment, decision making, professional identity, reflection, and this can be done in a real patients, community, OPDs, and field postings. And here, the outcome of experiential learning is the competency. For example, if you take a diet chart, if you take it as a practical, the students will prepare a diet chart, teacher will check it, and that's all, it is finished. But if you took it from an experiential point of view, student will interview the patient, he understands and learns the preferences, food preferences of a patient, understand the financial limitations, understands various other things, designs a diet, counsels patient, and reviews after 1 month, modifies advice, reflects on why adherence failed. So this creates a competence clinician. So practical training teaches how to perform a skill, whereas experiential learning teaches how to become a clinician. Coming to the COP cycle, here how experiential learning is transformed into competency, we can discuss. We'll discuss this slide. In the previous slide, we distinguished how practical is differentiated from experiential learning. The question arises: does every experience automatically become a learning? The answer is no. Experience alone does not make a competent physician. Reflection experience transforms into a learning. David Cobb's experiential learning cycle, it provides a framework for this transformation. So what is this Cobb's learning cycle? Cobb proposed a learning is a continuous cycle with 4 interconnected stages: the concrete experience, reflective observation, abstract conceptualization, and active experimentation. So if you look into a stage 1, concrete experience, this is where the learning begins with a real patient, a real encounter, or a real life challenge. For example, a patient with Prameha is advised to avoid excessive carbohydrates, but he returns after 1 month with poor glycemic control because dietary advice was not followed. Now, we experience this situation in the OPDs very often, right? So this is where this is a learning, this is a starting point. So this shared experience is a starting point of a experiential learning. Now the stage 2 is reflective observation. The learner or student will try to understand why the patient failed. Was the counseling inadequate? Was the advice culturally inappropriate? Did I understand patient's socioeconomic status? Did I simply prescribe without listening? So reflection develops humility and critical thinking. Then comes the abstract conceptualization. Here, the learner learns a new explanation. He goes back to the Samhitas, he learns about Ahara Vidhi, Satma, Agni, Prakritis, etc. And he also learns what are the modern dietary guidelines. behavior counseling techniques, motivation interviewing. So this stage transforms experience into a scientific understanding. Coming to the final stage, active experimentation. Instead of saying, don't eat rice, the learner now says, let us assess your daily routine. What quantity of rice do you consume? Can we replace a part of it with the millets? Can we modify the cooking methods? Can we have some lifestyle modification along with this to improve your insulin sensitivity? So this counseling becomes patient-centered, right? So this is what we call as Yukti Pramani in Ayurveda. A physician constantly learns from his previous patients. Every patient become a teacher. So Charaka even has repeatedly emphasizing observation, inference, and continuous refinement of a clinical judgment. So NOPS model therefore aligns beautifully with Ayurveda clinical reasoning. Uh, a simple practical suggestion is that if we ask our students every day after OPD, then if they could note down one thing they learned in OPD, one mistake they made in OPD, and one question they still have regarding a patient. So this simple intervention will dramatically improve their learning process. So clinical experience without reflection becomes a routine, whereas clinical experience with reflection becomes an expertise. And even reflection is alone not enough. Students also need to have a right learning environment. Now, in the next slide, let us discuss the infrastructure necessary for competency-based education. So, competency doesn't develop by a curriculum alone. It needs a proper educational ecosystem. Many institutions focus primarily on the classrooms and lecture halls, but however, students need different learning environments, right? Like skill laboratory. It's a safe environment for the beginning. Students can make mistakes without harming patients, right? Then now there are a lot of emphasis has been given to a skill lab in every institute. So simulation reduces anxiety before real patient exposure, right? And we can have an yoga lab, we can have an nutrition lab where students can learn meal planning, diet demonstration, all right, and therapeutic diet preparation, practical counseling. So this bridges theory and practice. And the most important community field area. As a being a Swasthavrita, it's one of the greatest strengths where students can conduct school health programs, village surveys, lifestyle assessments, non-communicable disease screening, yoga intervention. So here the community itself becomes a classroom. So infrastructure alone is also not sufficient. Each and every department should have their own annual experiential calendar. They should have their SOPs, assessment rubrics, log books, faculty allocation. So competency is built through carefully designed learning environment. Along with that, even the infrastructure and the complete ecosystem is very much essential. Once the environment is ready, we must decide how students interact within it. One of the most effective strategies is a small group learning. Now, usually we have 6 to 10 students in every PG department. So if you could divide them into two or three each in a 2 or 3 groups, that will be make them and more active thinkers. Now, why small groups are needed? So when we have divide them into small groups, right, the students will discuss advantages. Every learner speaks, questions increase, peer teaching develops, faculty can observe the individual thinking and immediate feedback becomes possible. For example, if we look into a case of any Stawale, we can divide them into 3 or 4 groups. The first group will do a diagnosis and assessment, right? And the second group will have an assess of Agni, Patya, and they will prepare Patya, Apatya, etc. Identify the Nidanas. And the group three, they'll do a modern nutrition recommendations, calories, macronutrients, exercise, behavioral science, etc. And group four, they will have a patient counseling, motivation, goal setting, follow up, and communication. So once each group's present, we can ask that why did each group recommend something slightly different? So this discussion teaches students that clinical management is multi-dimensional. Now, the most important thing is the faculty. What is the faculty role? The faculty do not dominate the discussion. They just guide them, they question them, they clarify the doubts, they summarize and facilitate. So these small groups transform passive classrooms into collaborative learning communities. One excellent application of small group learning is case-based learning. Uh, Case-based learning it begins with a patient, not a chapter. For example, the case 45-year-old female with a PCOS, obesity, irregular eating, emotional eating, right? So, what would be your first question to this patient be, right? So, faculty usually guides what would be the, we can ask the questions to the students, what was a probable dosha, what lifestyle factors are contributing, which investigations are necessary, which counseling strategy are inappropriate. So students construct the knowledge. Case-based learning naturally integrates various, it's a multi-departmental one. So it usually integrates multiple departments, the Kaya Chikitsa, Swasthata, Yoga, Dravyaguna, right? Psychology, communication. So this mirrors real clinical practice. Most important golden rule is that the faculty moderates and students discover. Right? So cases transform isolated knowledge into integrated clinical reasoning. Sometimes even a structured case is not enough. We may deliberately present an unsolved problem to stimulate a deeper inquiry. And this brings us to a problem-based learning. So case-based learning gives student a patient, whereas problem-based learning gives students uncertainty. So, for example, we can give a problem statement that if a patient has followed Ayurvedic advice for all the 3 months, instead of improving, the weight has increased. Now, we can ask what happened, right? In this case, the students become curious. Even after following advice for 3 months, still the weight is increasing. So here, the learner, they identify the possible explanations. What was the cause? Why the weight increased? Like they try to find out the possible explanations, whether hidden sugars was there, compliance issues, sleep, stress, endocrine disorders, physical activity, or incorrect dietary advice, right? And then they study independently. Students search for classical texts, they go back to their the roots, their research papers, guidelines, behavioral sciences, nutrition evidence, and then faculty intentionally, in this sense, I think the faculty intentionally steps back, right? And in stage three, it's a collaborative solution. Groups reconvene, present evidence, debate, critically evaluate, and develop a management plan. So the advantage of this problem-based learning is that the students will have a clinical reasoning, their research skills improves, critical appraisal, teamwork, self-directed learning, and decision making improves. So these are all lifelong competencies, right? For example, instead of asking what is Viruddha Ahara, right? We can moderate it. We can present a case scenario where there has been increased metabolic disorders in the village. Seeing there, when we saw that and has observed that there have been increased in a intake of the processed food in that particular area. Now students can design a intervention there. So to sum up, case-based learning, it teaches students how to apply the existing knowledge. Whereas problem-based learning, it teaches them how to generate a new knowledge. So the difference between CBL and PBL, that is case-based learning and problem-based learning. Usually a structured case is used to teach in case-based learning, whereas here in problem-based learning, we have a trigger as a messy problem. And CBL is faculty guided and discussion oriented, whereas PBL is student directed and inquiry centered. Goal is application of existing knowledge, whereas in PBL, the generation of new knowledge, right? Now, upgrading collaborative knowledge synthesis. Many of us have conducted seminars for decades, but let us ask ourselves, are our seminars educational experiences or simply student presentations, right? The traditional, what we do in our seminars, student prepares a slide, they read the text, and at the end, we the faculty ask 1 or 2 questions and the program ends. So this is what happens in a general traditional seminars. Now there is a new format. It is a flip-flop format. We'll flip the format. Instead of presenting information, student will analyze the information. For example, on Viruddha Ahara, students that compare the classical reference from various samhitas and they bring out the contemporary nutritional evidences. They also refer the systematic reviews, clinical implications, right? And then present it. And now the seminar becomes more analytical rather than a descriptive. And even the journal club, the traditional format, what we use is the student summarize abstract. We have a very little discussion in that. And now if you look into the modern format, now students critically appraise the paper, whether various guidelines have been followed. For example, CONSORT guidelines, PRISMA guidelines have been followed. What was the risk of biases? And in journal club, the methodology is discussed, validity is discussed, clinical relevance is discussed, and its applicability to Ayurveda is discussed. And the faculty role here is to check whether this methodology, they guide the students to ask whether the methodology has been appropriate. Can the findings be really applied to the Ayurveda practice? What are the limitations? Does this support or challenge classical concept? So here the goal is not information presentation, the goal is knowledge synthesis. After seminars and journal clubs, the next step is learning into a clinical real settings. So the clinical experience. Now, no pilot learns entirely on a simulator. Similarly, no doctor learns entirely in a classroom. Competency requires progressive exposure. Now, skill-based learning and simulation. In this, the student first practice in a safe environment. For example, we can have a simulations, or you can have we can ask the person, we can have the student to take a diet history, Agni assessment, Panchakarma preparations, lifestyle counseling, yoga demonstration. Here the faculty observes. Here the faculty observes,
മ്യൂട്ട് ഇല്ല അല്ലേ?
corrects immediately, and the students repeat until proficient. And the second model is bedside
ഇതിലൊക്കെ
teaching.
എന്തിനാ ഇത് വീഡിയോ ഓൺ ചെയ്തിട്ടിരിക്കുന്നത്?
ഭ്രാന്ത് കുറേ എണ്ണത്തിന്
The second module is bedside teaching, where the students enter the OPDs or IPDs. They observe various parikshas, for example, Ashtavida parikshas, right? They formulate ahara, they formulate medication, they formulate patya, they formulate yoga, and they do follow. Here, students also learn empathy. So the important point is that the simulation teaches the procedure, whereas the patients teach them the professionalism. Every bedside session should conclude with reflection, feedback, and learning points. Otherwise, students will simply keep observing. Now, how can students in our OPD independently counsel patients before faculty intervention? Right? So even in the classical Gurukula training, which used to occur on the bedsides, students used to observe the gurus and then gradually manage pension themselves. And today, even our syllabus or NCE of education revives around the same philosophy. So simulation prepares the students, patients complete their education. Having understood the learning environment, let us see how the practical skill should be taught. So competency developed through progressive entrustment, not by asking students to perform procedures suddenly. So we have 5 steps in it. The first one is demonstration. Here the faculty performs, students observe. The faculty explains each and every step, discuss common errors. Step 2 is written demonstration, right? Students repeat, faculty corrects, immediate feedback, no shortcuts. Third step is simulation. In simulation, student practice repeatedly. For example, it may be on a simulation lab, or it can be even on the mock patients, Panchakarma equipment preparations, yoga posture corrections. So mistakes are encouraged because they are safe. The fourth step is bedside teaching. Students now perform with real patients and the faculty supervises. Feedbacks becomes more nuanced. Communication becomes important. And the last one is OSCE preparation. Students now demonstrate standardized competence. Assessment becomes objective. Rubrics improve the fairness. So never skip the stages. Skipping simulation often produces anxious learners. So the take-home message is repeated supervised practice develops confidence, and confidence develops competence. So far we have discussed about classroom and hospital learning. There is one more thing which also we have especially Swasthavrata. It is the society, where society itself becomes a learning laboratory. Health is created where people live, not where hospitals exist. So this education must extend into the community. Students can be given various tasks. I mean, in school health programs, students learn, for example, preventive pediatrics, nutrition education, yoga promotion, hygiene, communication with children. So this develops public health competencies. And epidemiological field visits. Here, students conduct health survey, risk assessment, environmental mapping, water quality assessment, sanitation evaluation. So they appreciate the social determinants of the health. And there is one more zone, village adaptation and posting. Students follow families in this zone longitudinally. They observe lifestyle, seasonal variation, chronic disease progressions, compliances, behavioral change, etc. So this creates continuity of care. The most important thing is the benefit of this is that hospitals usually treat the disease, community prevent the disease. So every community visit should include learning objectives. We should include checklist, reflection, community feedback, and student presentations. Without reflection, it becomes merely a exertion. So a community is not an extension of classroom; it is a classroom itself. So up till now we have what are the things we have to build up an teaching ecosystem. Now, competency based assessment, what measures or measuring what matters. One of the greatest truth in education is that students learn what we assess. If we assess only memory, student will memorize. If we assess their clinical competence, they will strive to become competent clinicians. Now, if you look at traditional assessment methods, usually we have a one long case, voice, social skill, communication, right? Now we have a new concept we called as an OSCEs, DOPs, etc. will be discussed later on by other experts here. Now, objective structured clinical examination, that is OSCE. It assesses, for example, BP measurement, diet counseling, Prakriti assessment, yoga demonstration, etc. The advantage is that it is standardized, objective, and multiple competencies are assessed in it. DOPS, that is direct observation of procedural skills. Here the faculty directly observe procedure, like how the student is doing Nadi Pariksha, how the various Basti Dravyas are being prepared, how Nase is being administered, how the student is giving a yoga instruction. So immediate structured feedback follows. Similarly, we have mini-sec, that is short bedside encounter, which assesses history taking, clinical reasoning, patient interaction, etc. So assessment becomes meaningful only when it is aligned with teaching and learning outcomes. So here I made a brief mapping where we have, learning outcome is mapped with practicals, experiential, and learning one. Now, if the outcome is health and lifestyle evaluation, practical shows how, that is skill lab, role play of lifestyle protocols, etc. In experience, the students will be able to do it in independent assessment in independent OPDs. The assessment will be DOPS and mini-X. Now, most important is we talk of so much of it, but still we will have some hurdles. That is time constraint and high ratios, faculty resistant to change, and subject to assessment. Now, how can this be improved? I have prepared a brief solution also here. Now, evolution of an Ayurveda educator from lecturer to a facilitator. Now, the role of a teacher has now changed more in the last decade than in the previous 50 years. A traditional teacher usually he was a source of knowledge, he was a lecturer, examiner. Now, with the modern faculty, now teacher role has changed. Now, the teacher is a facilitator, he's a mentor, he's a coach, he's a clinical supervisor, he's a role model, he's a feedback provider, reflective practitioners. So faculty also need a lot of competency. That is what our president sir was telling in the initial in his remarks, that even faculty have to be trained. That is why we have this faculty development lectures, FD programs. So teachers themselves should have developed competencies in adult learning, educational technology, feedback, rubric development, workplace based assessments, research methodology, educational scholarships. Right now. Even the in our acharyas, they used to be a mentor, they used to be ethical guide, and they used to be role model also. and even the modern faculty development also revives around the same tradition. So competent teachers create competent learners, right? Now, here we have architecting the future of Ayurveda, the 5 strategic shift in education. Now, we need to have from a teacher centered to a learner centered. The faculty role transitions from a primary information provider to a facilitator of a student led inquiry. Competence based education is not teaching more, it is how we teach it differently. We have a, pardon. Yeah. Second shift is from knowledge to competency. Third shift is from lectures to experiential learning. Fourth shift is from single exams to continuous assessment. And fifth shift is from isolated department to community oriented. So this is how we need to shift in a education, higher education. The ultimate outcome is we need to develop, quality implementation ensures students graduate not just with degrees, but we need to make them a competent clinicians, lifestyle consultants, public health experts, and ethical professionals. With this, I thank everyone for their patience listening. If any question answers, I'm free to answer.
Thank
I
you, sir.
thank I thank the NCSM for giving opportunity to interact with you all. Thank you, sir.
Thank you, sir, for explaining the difference between these two part, practical and experiential learning in a simple way and with giving very meaningful examples. If any participant having any query, kindly put their queries in our blogs. Okay, no problem. We next move to our next lecture. That is our fifth session. The topic is trustable professional activities and workplace-based learning. That is WPBL. For this session, our resource person is Dr. Ritesh Gujarati sir. So I request our moderator, Dr. Morana sir, kindly introduce briefly our resource person. Morana sir.
Yes, sir. So it is my great honor and privilege to introduce our esteemed speaker, Professor Dr. Ritesh Gujarati, a distinguished academician and expert in the field fundamental principle of Ayurveda. Dr. Gujarati is currently serving as the professor and head of the department of the basic principle at G.J. Patel Institute of Ayurveda Science and CBA University, Anand, Gujarat. He has completed his BAMS from North Maharashtra University and his MD from prestigious institute, that is IPGTRA, Jamnagar, and he has completed his PhD from Tilak Maharashtra Vidyapit, Pune. With 19 years of teaching experience, he has made outstanding contribution in the Ayurvedic education and research. His academic accomplishment include authoring 4 books, publishing over 31 research papers, and delivering more than 170 invited lectures across the various institutions. He has served as research person for numerous faculty development programs, seminars, webinars, and curriculum development initiatives. In addition to his academic excellence, Dr. Gujarati has extensive experience as an assessor with NABED and NABH under the QCI and a visitor of NCSM. He has played a significant role in the institutional assessment, accreditation processes, quality audit, and the implementation of quality standards to promote excellence in healthcare and education. We are truly privileged to have such a distinguished scholar and inspiring leader with us today. Thank you. I welcome Dr. Ritesh Gujarati. Please, sir. Over to you.
Thank you, sir. Just let me share the. Sir, I hope the slides are visible.
Yes, sir.
Okay, sir. Thank you. Thank you for confirming. Thank you.
Yes, sir.
Thank you, ma'am. So, a very good afternoon to all the distinguished faculty members and dear PG scholars. At the outset, let me extend my cordial congratulations to the President, Board of Ayurveda, Allam Prabhu Gudda, sir, and other members of NCISM, the organizing team of this FDP, for coming up with the idea for the faculty development program for postgraduate teachers as well as faculty members. Today, I am interested with the topic Entrustable Professional Activities, that is EPAs, and work-based learning. Let me share. So the content that has been shared with me by NCISM, that what I am supposed to speak, that is, first we'll see introduction to EPAs and their relevance in CBDC, OBDC, relationship between competencies, milestones, and EPAs, identifying EPAs in Ayurveda PG training, workplace-based learning, that is WPL, and WPA, that is workplace-based assessments. In that, I'm supposed to cover mini CAX, DOPS, as the rest of the two topics, that is case-based discussion and direct observation, will be covered in tomorrow's presentations. After that, we'll be talking about feedback and remediation strategies, and then documentation of entrustment decisions. The learning objectives that has been decided is understand the concept of entrustable professional activities, that is EPAs, link competencies to real-world clinical and academic responsibilities, assess learners in authentic workplace settings, that is WPBAs, and make entrustment decisions based on observed performance. Now, coming to introduction to EPAs and their relevance in CBDC, let me first put the question in front of you that would you allow a resident to independently manage a complicated Ahmad case or perform a Panchakarma procedure or perform a surgery to one of your family members if needed? Or if needed, guide an undergraduate clinical posting or present a treatment plan in multidisciplinary team. So this is about trust, whether we are going to trust our postgraduate scholars to perform these various professional activities. If the answer is yes, then very good. It means they have achieved those EPAs. But if the answer is no, or it depends on scholar to scholar, then this session is about how we are going to entrust our PG scholars with the professional activities and what is the mechanism for that. And most important is what evidence would make you trust your resident, that what document you want, what skill you want, so that you can entrust your PG residents with all those EPAs, that is professional activities. Now, when we talk about our traditional assessment methods, in traditional assessment methods, residents pass written exams. They are also clearing their final year MD or MS examinations, but sometimes still faculty hesitate to allow independent clinical practice. So to answer this question, we need to follow the path for EPAs. In current PG assessment, we assess our residents through theory examinations, case representations, seminars, journal clubs, dissertation work, practical examination, but still somewhere we are not trusting them. The reason is because in Miller's pyramid, the four levels are there. At nose level, the assessment is done through theory assessment. At the level knows how can be assessed through vivas. The level shows how can be assessed through practical examination. Whereas for does level, workplace-based assessment is very much required, and somehow this is missing in our current system, and this is the purpose why these kind of sessions have been arranged. Now we must understand why this is happening, because there is a gap between knowledge to competence, competence to performance, and performance to trust. Until and unless we bridge these gaps, we will not be able to entrust our PG resident. So talking about the Miller's pyramid, when we talk about the topmost level, that is does levels, EPAs are going to help us to assess the does level. Coming back to our competency-based medical curriculum, or CBDCs, or for post-graduation, we call it as OBDCs. So in competence-based medical education, 2 EPAs, we are going to need various attributes should be there with our residents, various competencies like communication skill, clinical reasoning, and professionalism, along with their clinical skills. If everything is achieved, then by the end, we can say that they are in a position to enter, they are in a position that we can entrust them with certain professional activities. For example, the EPA will be like conduct an Ayurvedic consultation independently. Now, when we talk about EPS, we must understand that a resident may possess individual competencies, because since last 5 years, we have been talking about competencies. At UG level also, competency-based dynamic curriculum has been introduced. There also certain competencies have been identified. We are going through the syllabus, we are assessing those competencies, and at the end, we are certifying our UG students that they have achieved the competencies. But entrustment occurs only when these competencies are integrated in real practice. So to just see one example, for example, here you can see competencies are like the ingredients, whereas EPA can be considered as the final dish or final outcome which has been prepared. Now, what is EPA? So EPA is nothing but, or EPAs are nothing but the units of professional work that can be entrusted to a learner, that without supervision also our PG resident can perform these activities. And the components for EPAs are knowledge, skills, attitude, communication, ethics, and professionalism. Now let us see, because when we talk about the concept of EPAs, this concept is not that much old. Worldwide, the competency-based medical education was started around 2000. By the end of 2005, one professor from Netherlands, Professor Ole ten Cate, he came up with a question, or rather problem, that though this competency-based medical education has been adopted, still somewhere we are not able to trust our residents, or we cannot entrust them with certain professional activities. And he introduced the concept of EPAs in 2005. Gradually, this concept was accepted worldwide, and by 2014, Association of American Medical Colleges, they came up with the concept that yes, there is a gap between theory and practice, and we need to bridge that gap. And they thought that EPS is a concept which is going to help us to bridge this gap. So worldwide, the concept of EPS started, like clinicians started using EPS from 2014. Now, when we talk about Ayurvedic learning methods or teaching learning methods, we must understand that the concept of EPAs or concept of WBL or WPBA, these words, it looks fancy, but somehow when we compare it with the traditional Ayurvedic education, we must understand that these concepts are nothing but the old wine in new bottle, because all our faculties, all our scholars are going through rigorous clinical training, and somehow we are doing, or rather we are entrusting our residents with various professional activities, but somehow the documentation was not there. So EPAs, the concept of EPA, concept of WBL is going to help us that how we can make more refinement in that documentation also. So now let us see one example of an EPA for one department, that is for Panchakarma, perform Panchakarma procedures safely. So that can be an entrustable professional activity where the faculties of Panchakarma department will entrust their residents. So now what competencies are required for that? Procedural skills should be there, safety aspect should be considered, and professionalism should be there. So these are the competencies that should be there. Now, what is the relationship between the competencies, milestones, and EPAs? Because till 4th year as well as in our PG syllabus, various competencies have already been identified. But now the journey of how we need to move it from competencies to milestones and milestones to EPAs, that is what we are going to see. So these competencies, milestones, and EPAs must be considered as the building blocks of competency-based education. It is nothing but like building a house. Like when we are training a PG scholars, it must be compared with building a house. So competencies are the ingredients, whereas milestones indicate the level of development, how are PG residents progressing, and EPAs will be the final outcome, are the real world professional work. So competencies describes the doctor, whereas EPAs describe the work of the doctor. Now, there is a hierarchical relationship between competencies, milestones, and entrustable. At the base, there will be competencies which will be followed by the milestones that our scholars are going to achieve in due course of time. And finally, they will reach to a stage of entrustable professional activities. Now, this is one more EPA, that's conduct and manage Panchakarma therapy independently. Now, what competencies are there and what milestones are there that we can see? Say, for example, the first competency is clinical assessment. And for that, the milestone will be accurately selects eligible patients. The next competency will be procedural skills, where the milestone will be the resident is in a position to perform woman under supervision. The next competency will be patient safety. Here, the milestone will be the patient has identified complications at a very early level. Then the next competency will be communication. The milestone will be, yes, he regularly takes informed consent from the patients. And professionalism comes with a milestone that the resident properly maintains the record and follows the ethical conduct. So this is how for every EPA, certain competencies and certain milestone will be there. Now, how the entrustment decision has to be taken. Say, for example, when a resident is observing when the faculties are observing the residents, the question will be, can I trust this resident to perform and manage Panchakarma safely without either indirect supervision or direct supervision? If the answer is yes, then the outcome will be EPA is achieved. If the answer is no, then certain feedback is required, reflections are required, plan for improvement is required, and then the EPS can be achieved. Now, this is the competency milestone EPA pyramid. Here we can see at the base, these competencies like from knowledge, skill, attitude, and values, they lie at the bottom. Then gradually in the due course of time, 3 years, gradually the scholars will be, the residents will be achieving the milestone, and their progress will be observed by the faculties. And EPA will be the final outcome, that is their real world professional work that they can be interested with. Now, say for example, a competency in a clinical examination, the milestone will be performs the examination accurately under either indirect supervision or direct supervision. And final outcome will be, now we can entrust the resident that they can independently evaluate and manage a patient in OPD. So it is like moving the resident from dependency to an independent practitioner. Now, what is the outcome? So here we must understand that the competencies answer what abilities should a PG possess. And that's why all these competencies have already been enlisted in our syllabus. So this is our final outcome, that, okay, they need to achieve these abilities. Milestone will be how far has the PG progressed. So during the 3 years of course, regularly the guide as well as other faculties from the department, they will be observing the residents in real time scenario, and they will be documenting that how far they have progressed. And EPS are going to answer what professional work can the PG be entrusted to do independently. Now, competencies can be considered as the bricks when we are talking about PG training, which is almost similar to building a house. So competencies can be considered as the bricks, whereas milestones are the levels of construction, and EPA are the finish rooms that can be safely occupied. So that is the final outcome that we are supposed to get by the end of that 3 years of curriculum. So faculty observes competencies, not only one, all the faculties are going to observe, all the faculties are going to give their feedbacks, and accordingly, the progress of the resident can be noted. They judge the milestones and finally make entrustment decisions through EPS. How it can be done, that we are going to see. Now, identifying EPS in Ayurveda pediatric, we must see that in our syllabus, only competencies have been enlisted. Now, each and every department or the university boards need to sit together and they need to finalize the EPS for each and every department. So, for example, I have prepared almost EPS for all these departments, but due to the lack of time, we'll be only going through the EPS for Kai Chikitsa. For example, the first EPA should be, it is not mandatory that Kai Chikitsa department should follow. All the faculties of Kai Chikitsa department should sit together. You are the expert. You should decide that what professional activities you are going to entrust to our residents. So independently assess, diagnose, and manage a patient with common chronic disorders using Ayurvedic principles. That can be a first EPA. Develop and implement a comprehensive treatment plan integrating Shodhan and Shaman. That can be considered as a second EPA. Manage emergency situation encountered in an Ayurveda hospital and initiate appropriate referrals. Even referring the patient at the right time, that can be a very important EPA. Conduct multidisciplinary case discussions and justify Ayurveda clinical decisions. They should be in a position to give the reasoning that why this treatment plan has been, why this care plan has been identified. Then provide a long-term follow and outcome evaluation of chronic disease patients. And the last EPA, that is EPA 6, can be applicable for almost each and every PG specialty. That is teach and supervise undergraduate clinical posting. So by the end of 3 years of post-graduation, they should be in a position to teach and supervise the undergraduate students. So the point of discussion will be, can a MD or MS resident or postgraduate be certified without demonstrating entrustment for specialty specific EPS? Currently, we do not have the system. We have only identified the competencies, but now we need to move from competencies to milestones and milestones to EPS, and there should be a process that before the resident appears for his final examination, he needs to be, or rather we must certify him with certain EPS that he will be interested to do independently in the society. So this shifts the conversation from what has the student studied. This is what we are assessing now. What has the student learned or studied in the last 3 years? Rather, it should move to what can the student be trusted to do independently. And this is this is the essence of CBDC, that is competency-based dynamic curriculum and EPA framework. So gradually, as at UG level, we have started already assessing the competencies. For post-graduation, we need to move from competencies to EPS. Now, workplace-based learning. How we are going to achieve these EPS? Certainly for that, workplace-based learning and its monitoring and its assessment is going to play a very important role. Now, coming back to Ayurveda PG workplace in any Ayurveda institution, certainly it will be general OPDs, specialty OPDs, IPDs, Panchakarma units, labor rooms, operation theater, diagnostic laboratories, pharmacies, community health programs, and undergraduate teaching sessions. So these are the areas where our residents are going to work. Now, why WL is important? Because in traditional teaching, the knowledge can be assessed through examination, whereas work-based learning is going to ensure that there'll be real life experiences will be there. There'll be reflections, that is internal evaluation by the resident himself. Then there'll be feedback by the peers and ultimately an improvement plan, which is the outcome of reflection and feedback, and which will make sure that the resident is going to achieve the EPS at the end of the 3 years of course. Now, what is the learning cycle? First, there'll be clinical encounter in the hospital. Then there's the observation. The resident will be closely observed and monitored by the faculties of the department as well as PG guide. Then the feedback will be given. Then the reflection will be there. Feedback will be provided by either the guide or all the faculties from PG department. Reflection will rather be like an introspection kind of thing. And then whatever clinical encounter was there, by the end of observation, feedback, and reflection, certain plan will be prepared, and that is going to help the improve the performance of the resident. So this cycle needs to be continued till the EPS are achieved. As I told in the beginning, that the concept like EPA or WL are not that much new. Because when we talk about our traditional Gurukul system and the beautiful quotation from Ashtangruday, which clearly says, Abhyasat prapyate dushti karma siddhi prakashani, ratnadi sadasad jnanam na shastra eva jayate. So in almost all the samhitas, repeatedly it has been told that mastery develops through repeated supervised practice. So that supervision needs to be done by our PG faculties. So Ayurveda education has historically been workplace-based, although not formally labeled as such. So these concepts are though Western concepts, but we have been doing this in our clinical setup since ages. Now let us see the example from Shalya department. Like in workplace, for example, if a workplace is surgical OPD, what WL activity should be there? So to evaluate anorectal disorders. Workplace, if it is an operation theater, then the WBL activity will be assist and progressively perform procedures. In ward, manage post-operative patients. In dressing room, perform wound care. In emergency unit, triage and initial management of surgical emergency. So these will be the work-based learning activities that we need to conduct for our residents. Now, after this work-based learning, there should be assessment. And that's why it is WPA or WBA, that is workplace-based assessment. Various sources are required for that. Out of that, mini CEX, DOPS, case-based discussions, and direct observation. We are going to see few examples of mini CEX and DOPS. So what is mini CEX? It is nothing but mini clinical evaluation exercise. Even this concept we have introduced at UG level also. So mini CEX is a workplace-based assessment, which is more applicable in PG than undergraduation. This is a tool in which a faculty member directly observes a postgraduate student during a real patient encounter and provides structured feedback. What is the purpose of this? So assess clinical competence in real settings, promote learning through feedback, monitor progress over time, and support the competency-based and EPA-based assessment, which is going to help the resident. That should be a personal feedback. Now, what is the cycle? Let's see. In mini CEX, the typical duration will be for every resident, it will be a 10 to 20 minute observation. Feedback one-to-one needs to be given for 5 to 10 minutes. How we are going to assess? What we are going to assess? History taking, clinical examination, clinical reasoning, why this decision has been taken, the guidance about communication skills, how the scholar or rather resident is communicating with the patient, and professional behavior. So all these things are going to lead to organizational setup and how efficiently our resident works in a professional setup. What is the process for mini CEX? As usual, first there'll be patient encounter in the hospital, then direct observation by the faculties, then the assessment will be done by the faculties, then there'll be feedback, reflection, and finally, action plan can be sorted, which can guide our resident in due course of time. Now, what domains are going to rate here? So, for example, in this example, say history taking, for that domain, assessment focus should be relevant and systematic information gathering, whether it has been done or not. For examination skills, whether proper clinical examination has been done or not. For clinical judgment, whether the diagnosis and management planning or care plan was designed properly or not. In communication, whether proper patient interaction and counseling was there or not. In professional behavior, whether the ethics, respect, and empathy were there or whether it has been followed or not. In organizational setup, time management and efficiency plays a very important role. And for overall competence, global performance is going to be assessed. Now, let us see one more example here. For example, resident evaluates patient for woman therapy. So what faculty is supposed to observe? How the patient selection has been done, assessment of the indications, explanation of the procedure, safety precautions, and documentation. These are the steps. How we are going to give the feedback? Feedback should always be balanced. It should never be punitive. It should never be only one-sided. So if the resident has done well, then appropriate patient selection, that feedback can be given. If some improvement is required, then the feedback should be discussed possible complications more clearly during the counseling. What will be the competencies which will be assessed for this EPA? Procedural readiness, how he is ready, how he communicates or how she communicates, whether the patient safety aspect has been dealt with properly or not, and whether the behavior was professional or not. Then the next WPA-BA is DOPS, that is direct observation of procedural skills. How we are going to assess the preparation and planning by the resident, what other technical skills he has applied, whether aseptic and safety practices have been identified if it is a surgical procedure, communication and consent, professionalism, and post-procedure management if it requires. Now, what is the DOPS assessment cycle? Here, first there will be direct observation, then a structure assessment will be there. Immediate feedback needs to be given. Feedback should be given in such a way that it should be actionable. So action plan needs to be prepared with your guidance, and then the assessment will be repeated. So this cycle we need to repeat until and unless the resident achieve those EPAs. So DOPS evaluates not only whether a learner can perform a procedure, that is not our goal, but whether it can be performed safely, effectively, professionally, and most important, independently. So core domains which we generally assess in DOPS, say for example, for knowledge of procedure, what are the indications, what are the contraindications, what are the steps that needs to be assessed. For preparation, what are the equipments, how the patient has been prepared. For communication, consent and patient explanation, whether risk, alternatives, benefits have been told or not. For technical skills, correct execution of the procedure as per SOP, whether he is doing it or not. For infection control and safety or sepsis complication prevention, if it is a surgical procedure. In professionalism, we need to check whether he was respectful and whether the ethical conduct was there. And in post-procedure care, whether the documentation and follow-up is proper as per the guideline or not. Let us see one more example for Shalya Tantra. For example, Kshar Sutra application. Now, what faculty is going to observe? Whether the patient has been prepared properly, whether the aseptic precautions are taken care of, technical execution of the process, hemostasis, and finally, documentation. The feedback can be, if it has been done properly, excellent issue handling. If some improvement is required, then improve explanation of aftercare instruction after observing in whichever areas you feel that the resident is lacking, that improvement, actionable feedback needs to be given. The competencies that we are going to assess is surgical skills, patient safety, communication, and professionalism. Now, from competencies to milestones to WBL to WPA, the next and most important is, because all these activities will fail if the feedback and remediation strategies are not properly applied. So why feedback is that much central to WBL and EPA? So here, as we have seen previously also, we are going to observe, we are going to assess, feedback is going to be provided by the peers, reflection will be internal, introspection by the resident himself. Improvement plan will be chalked out with the help of the guidance from faculties, and then again the resident is subjected to reassessment. So this is the cycle we are supposed to follow. Now, what should be the criteria for feedback? First and most important, it should be timely, preferably immediately. It should be based on direct observation. It should be specific and objective. It must be balanced. So it should have a combination of strengths as well as areas of improvement. And whatever feedback we are going to provide, it should be actionable. The resident must understand it and he should be in a position to implement it. And most important, it should encourage the self-reflection. This is one more feedback framework model, which is known as Ask, Tell, Ask model, that can also be applied. Even various models are there. You can search Google and you can apply them as per your comfort. Now, what is asked? So how do you think the procedure went? This is the first question that the faculty is going to ask to the resident. Let the resident answer how the procedure has gone. Then faculty is going to provide the observation. What do different next time? So that will be the actionable plan the resident is supposed to follow. Now let us see, this is the feedback for EPA assessment. Manage a patient with Sandivat independently. Now faculty observations are there, clinical reasonings have been checked, communications have been checked, documentation have been checked, treatment planning have been checked, and most important, at the end, follow-up suggestion needs to be given. Now, we cannot give the feedback like you passed. That will not be a genuine feedback, because this feedback is not going to help your resident. So the feedback should be balanced. You can manage straightforward Sandivat cases independently. It is a positive side of the feedback, but complex cases with multiple comorbidities will require supervision. So this is the area of improvement. So next time the resident should follow this. Now about remediation strategies in WBL and EPA. What is remediation? We have been taking remedial classes for our UG students also. So it's a structured educational process designed to address identified performance gap. In that whole process, if you have identified certain gaps, we need to fill those gaps, we need to bridge those gaps, then this is required. So common areas requiring remediations will be clinical reasoning. There your resident is going to help you. Procedural skills, technical skills rather, communication skills, documentation, professionalism, and patient safety practices. There are fair chances that in these areas, the gaps will be there and we need to provide the feedback. So this is the remediation process cycle. First and most important, we need to identify the gap. We need to identify the cause, why it has happened. We need to create a learning plan which is specifically for that resident. We cannot identify the gap for 5 or 6 students altogether. So this should be an individualistic feedback. Then a targeted practice needs to be done, repeated observation, and again reassessment. So this is the remediation process we need to follow. For example, now here the problem is resident is unable to perform woman procedure safely. Now what should be the remediation? Demonstration needs to be done by the faculty himself or herself. Supervised procedure needs to be conducted. Reflection log is to be created. Documentation needs to be maintained, and repeat the DOPS assessment. Now, faculty strategy. What should be the faculty strategies for effective remediation? First and most important, like a feedback, it should be early. It should be supportive. It should be non-punitive. It should be individualized. We cannot give remediation to a group of PG scholars. It should be documented because it is going to help him or her in due course of time, and followed by reassessment. Remediation cannot be completed without reassessment. Now, what can be the toolkit the faculty can adopt? For example, if there is a knowledge gap, then remediation method will be directed reading can be advised or tutorials can be conducted. If there is a clinical reasoning gap, we can more focus on case-based discussions. If there is a procedural skill gap, then the DOPS or simulation or repeated supervised practices can be adopted. If there are communication issues, then role play or patient encounters will be beneficial to the residents. And for professionalism concerns, mentoring and reflective exercises are going to help the resident. So we must understand that in competency-based education, the goal is not to identify weak learners. We are not here to identify weak learners, but to identify learning needs in a very early stage, giving the genuine feedback, giving the scope for reflections, and provide structured opportunities for improvement, and most important, until entrustment can be safely guaranteed. So until and unless that entrustment is granted, we need to repeat the procedure. Whereas feedback tells the learner where they are. Remediation is going to help them reach where they need to be, and EPS are going to determine when they are ready to practice independently, and that is our final goal through the process of these competencies, feedback, remediation, and independent practitioner. Now, what documentation is required for entrustment decisions? Because the final entrustment reward will be now you can independently do this kind of professional activity. So what is the entrustment decision? And entrustment decision is a faculty judgment that a PG scholar can perform a professional activity with a specific level of supervision. So first we need to decide the EPS for that specialty, and by the end of the 3 years we need to certify the resident that you are interested to perform these professional activities. What kind of documentation is essential? Provide evidences for progression. Ensure transparency and fairness when the documentation is maintained. Support competency-based assessment. Facilitate faculty consensus, because the same resident is going to be observed by multiple faculties in the same department or specialty. Identifies learners requiring remediation at a very early stage and providing him or her a good feedback. Creates an auditable record, because now auditing is very much important. Since last 2-3 years, we are all going through all these QCI visits. So for post-graduation also will be there in future. So for that, we need to have such kind of records. And most important, entrustment should be based on documented evidence from multiple workplace observation. This entrustment decision cannot be based only on one person's feedback and one place observation. So this is important. So how we are going to do this? So what should be documented? So EPA being assessed, that should be documented there. What are the evidence that we need to document? How you are reached to the conclusion, your observation, and most important, final certification that the resident has achieved that EPA. What will be the sources? These are the sources that we are going to get from WPA, BA. that is mini CX, DOPS, case-based discussion, direct observation, even MSF, that is multi-source feedback, logbook portfolios, and reflection reports. All these sources is going to help us to conclude. Now, how you are going to certify? Objective parameters should be there. For every time we are, for every activity, for every competency, there's a rating scale from 1 to 5. We need to summarize it. And by the end, if the average score is less than 2, then we can say the resident is not interested. If between 2 to 2.9, we can say direct supervision is required. In 3 to 3.9, we can say indirect supervision is there. And from 4 to 4.4, independent practice can be allowed. And more than 4.5 out of 5, if the score is there, then we can say now the resident is ready to supervise and teach the juniors. This is only a sample rubric. You can have your own rubric at your institute or university. Now, what are the best practices for Ayurveda PG programs? All this documentation needs to be maintained in a portfolio. So the portfolio must have list of specialty specific EPAs. So we need to create EPAs from the competencies, then workplace-based assessment records, entrustment decisions, feedback reports, remediation plans, reflection notes, and faculty review summaries. So all these documents are going to help us to give final reward of entrustment. So what is the entrustment rule? A final entrustment decision should ideally be based on most important thing is multiple observation. With few observation, we cannot take the decision for entrustment. Also, not one person, not only guide the whole department in that specialty should note their observations, and from that only the certificate, the entrustment decision should be taken. Multiple clinical context should be there, and most important, longitudinal evidence over the time. Over the course of maybe 6 months, 1 year, all these documents needs to be maintained, and then final decision related to entrustment can be taken. So this was all about EPAs and WBL. It is not possible to complete the core topic of EPAs with all the WBL and WPA, but within almost, I think, 14 minutes, whatever time and whatever content I could deliver that I have prepared. So once again, thank you very much for your patient listening. I also extend my sincere thanks to Board of Ayurveda organizing team for providing me the opportunity to be a part of this August gathering. Let me leave you with this beautiful thought, and which is most important for all of us as postgraduate teachers, that the ultimate outcome of postgraduate Ayurveda education is not a degree, but a professional whom not only patient, not only institution, but society can also trust. So thank you very much. Over to you, sir.
Thank you, sir. Thank you, sir. Thank you very much, sir. You cover almost all things in 40 minutes. Very wonderful presentation. Sir, you will define, first of all, journey from the competencies to milestone and milestone to EPA, and also explain the DOPS, mini CX under the WPL. I am sure that all participants should use this knowledge for their postgraduate teaching in future. So really appreciate, sir, and thank you for giving the time. And if any participant have any query, open the discussion for a minute. Otherwise, we will start our next session.
Sir, Namaskar, sir. Myself, Dr. Babita Das
Namaste,
from
ma'am.
Bhopal. From Bhopal. I am
ma'am.
from Panchakam department. Sir, please clarify again the documentation part. What have to documented?
Okay. Ma'am, the documentation part will start from competencies, because first we need to list out the EPAs. Then only the procedure is going to start. So the first documentation will be EPAs. Then how we are going to achieve that EPA, for that we need to decide work-based learning, that is WBL. After doing WBL, the next step comes, that is WPBA. Which method you are going to follow, because multiple methods are done. And as I am told, even many methods are going to cover, assessment methods are going to cover in tomorrow's session also. So mini CX, DOPS, or case-based discussion. So we need to prepare the documentation. So by the end of 2 years, like 5-6 mini CX should be there, 5-6 CBD should be there. So it should be a cluster. We cannot take the entrustment decision only on the basis of mini CAX or DOPS, because all these assessment methods are focusing on different areas. And we want our resident expert in all these areas. So we need to create the documentation, and after that, when we are doing WPBA, what feedbacks have been given, what reflections have been done, what was the improvement plan, and at the end, certification. So these documents are very much required.
Okay, sir. Thank you.
Thank you. Thank you, ma'am.
Thank you, sir. Okay. Okay, thank you, sir. Thank you once again. Now we will move our today's topic is integrating research competencies into outcome-based dynamic curriculum. And for this session, the resource person is Dr. Pranita Joshi ma'am. So I request to Mohanna sir kindly introduce to our esteemed speaker.
Namaste, madam. It is my privilege to introduce Professor Dr. Pranita Joshi Deshmukh, an eminent academician, researcher, and healthcare expert who has made remarkable contribution to the field of Ayurveda and healthcare management. Dr. Pranita is accomplished and distinguished scholar with impressive academic background, holding
Sir, your
an
voice is cracking.
MD and PhD in Ayurveda and MA in Sanskrit, a diploma in therapeutic yoga, and a diploma in family welfare management from New Delhi, and an MBA in healthcare and hospital system management from BITS Pilani. She currently serves as the principal of Ma'am, is it audible? Sir, is it audible now? Sumati Bhai Shah, Ayurveda College, Pune, and is also the professor and HOD of Kriya Sarira and Research Methodology and Medical Strategy. She is the research coordinator for the Advanced Research for Ayurvedic Sciences. She is a recognized NABH IU's Principal Accessor, QCI Faculty, CIA Healthcare and Education Accessor, ISO 9001-2015, and she has also served as a Woman Scientist Fellow in Intellectual Property Rights under CSIR and is the Editor-in-Chief for the quarterly Ayurveda Research Journal, Sattva Anveshanam. So today, in recognition of our outstanding service to the society, she is a Paul Harris Fellow and Service Above of the Self-Awardee of Rotary International. So please join me in extending a warm welcome to Professor Dr. Pranita Joshi Deshmukh. Thank you, ma'am.
Namaste. Namaste, everyone. I request Dr. Kiran to make me co-host so that I can share my screen. Am I audible?
Yes, ma'am, it is audible.
Yes, ma'am.
So, by the time Dr. Kiran makes all the technical arrangements, I will just start my presentation with a brief introduction to this topic. And to begin with, I know the topics lined up for tomorrow and that we have already covered yesterday and today are so complex topics that they are not enough to justify in 40 minutes. So we are trying our level best to give proper justice to those topics and trying to explore all the avenues of that topic so that the inquiry is generated in your mind and we can explore those topics further. So let me just share my presentation and I will just get you through to the basics of research competencies. I hope my presentation is visible here.
Yes, ma'am. Visible.
Would you please confirm?
Yes.
And the slides are changing.
Yes. But your voice are
Okay. Sorry?
Ma'am, it is audible, no problem, ma'am. It is visible also.
Am I audible, sir?
yes,
Yes, ma'am.
but
Audible and clear?
Yes,
Slides.
yes.
Okay, thank you. So first of all, I would like to appreciate the efforts of NCISM and particularly Chairperson Madam Kothekar ma'am, Alam Prabhu Hooda sir, President BOI, the NCISM dignitaries, technical team, and FDA team to initiate this whole mammoth task to inculcate this practice of training the teachers. And today we are in the same domain where everyone needs to update themselves. And yesterday, as we learned that we have to also unlearn some of the things to be able to match up the competencies of the future doctors. Basically, my topic today is having the objective set by the NCISM. But I would just say that the finest potter who is making that art is not leaving any mark behind. That perfection can be seen in the art itself. So we have to also inculcate that finest quality so that it gets reflected in the competencies of our learner, our teacher, our students. And also, we also need to keep on learning ourselves and keep on updating ourselves as the next generation comes up. These are the 10 pointer objectives which I am going to cover today. But I will just mention that these are technical pointers. This may not be the sufficient time to cover each and everything in detail, but let me just open up the possibilities how these 10 pointers can create 10 possible avenues. Basically, yesterday we did, also witnessed the OBDC curriculum framework and how OBDC is developed with a vision. The vision to create a global leader in Ayush education, research, and healthcare. So that a future doctor can provide a holistic well-being care for everyone. And it starts with knowledge, then we turn to convert those knowledge into skills, ultimately how we are performing, those are our competencies, the graduate attributes like who we become at the end of the course, at the end of the program, and the overall impact on the society. So I always make sure that when the student is learning, particularly in PG course, whatever they do, they should have a 3-point checklist that self, society, and science. Whether the topic they are creating, whether the topic they are working on, the subject is enriching their own knowledge, is it beneficial for the society, is it replenishing something for our. So the first is like this potter develops everything with the raw material. We also need to understand what is the need of those competencies, particularly in OBDC. These numbers speak for themselves. This is based on the report generated from from Roots to Global Reach book, which is released by Ministry of Ayush in 2026. And it's very interesting book because it also covers all the transformative actions in Ayush, particularly for 11 years. So there is a huge market waiting for our students. Are our students ready for that market? That is the main question. And as these numbers speak for themselves, I will not go in the details, but you can just refer to the central aspect of this presentation slide, where rural populations are choosing and are aware about Ayush systems as equal to the urban population. So 95% rural population, 96% urban population. It's a good number. And wherever the student wishes to practice, there are takers for the Ayush system. There are takers who are actually proactively coming to the Ayush system for maybe their well-being, health promotion, longevity, disease management, and so on and so forth. So let us focus on the Ayush professional which we developed in year 2000 versus the future version which we need for Vikasit Bharat in 2047. Basically, now only clinical knowledge is not sufficient. As all the speakers are saying, we have to have a critical thinking and clinical decision making. Clinical skills are not sufficient nowadays because now you are seeing many new diseases, many new combinations of symptoms. One person with 3 different book pictures, and the problem solving for complex cell challenges is needed in the future, or I would say in the future learner of Ayurveda. Subject expertise is not limited to just Kriya Sharir or Swastha Vrutta, because the community is thinking that Ayurveda can provide more. And they might ask you certain questions, certain facilities, or maybe certain skills from, say, Panchakarma or Swastha Vrutta or even research. Teaching ability is not limited to the classrooms nowadays. As you can see, there is a vast community of influencers on the social media. Are we part of that trend? Are we putting the right word in the domain? Are we putting the right word in the public? So we have to teach with innovative teaching learning skills, and which can be transferred from social media to a classroom, to a research setting, to a community setting. Our students need to also teach certain practices and Sadhvrta.
Madam, your voice is not coming. Hello? Ma'am, no audio.
Practitioners. So we need to have a global a scientific vigor so that we can be an advocate for the future policies. Administrative experience and national perspective is very much important when it comes to the development of 2047 policies. Ethics are again important when we are practicing on various domains like social media, clinical practice, community best practice. Ethics are integral part of it. So how the shift is happening? Initially, the shift was totally cognitive centered, knowledge centered, teacher led, experience based, individual practitioner centric. The overall practice was limited to only one area, one city, or maybe one state, or just till our national demography. But now it is changing, it is shifting to a global practice. Even our day-to-day patients are travelers, they are globe-trotters. They are asking for diet which can be followed in US. When they come back to India, they can shift to an Indian diet. So the requirement is changing drastically. When it comes to the clinical care, we are no longer providers of only Ayush. We need to integrate our clinical and research innovation with other alternatives, other practices, other solutions. It could come from the diet, it could come from the physiotherapy, or maybe yoga, or maybe certain changes in lifestyle. So we have to be collaborative and integrative in nature. For the year 2047, we are already using various tools for teaching learning. We are already using smart boards. What happens in 2047? Maybe the learner might select a natural environment. They might select that, okay, I have all the gadget in hand, but I want a learner-centered approach. So strategic leadership, quality governance, as you can see, the Honorable President Sir just mentioned that this FDP is a continuous process. We have to keep on unlearning, keep on learning, and again back to updating ourselves. So outcome-based, impact-based, societal value-based systems are needed. How to define these competencies is a second part, and particularly for PG Ayush students. Even today, many community sections are not aware about the super specialization in Ayurveda. So how to tell them that what we have? Basically, if you see around us, particularly in India, we are surrounded by a timeless transition of technology and knowledge. We are surrounded by so many examples where the future is actually shown to us, that how the history was working on the competencies, how they were enduring the human capabilities. If you take an example of Ashokan Rock edicts, how the governance code of conduct was transmitted across India, how the strategic planning was done for the whole assembly of the Raigad fort, how a social problem of water sanitation, water storage was solved with Rani Ki Vav, where there was a water shortage. Critical thinking, like how an unrusting iron pillar can be established as a proof for that particular chemistry-based learning. These competencies are time tested. They are transit eras examples of competencies. In this particular session, I would like to tell you that today we are just 4 years away from a decade completion, 2030. And today only, out of these participants, like we are almost having 800 plus participants in this meeting, and again on the YouTube. Among this participant audience, we can see many as clinicians, academicians, already doing research, innovators with patents and copyrights in place, entrepreneurs with businesses like from dietary elements to the medicinal elements to the IT-based components. There are healthcare administrators, principals, directors, deans, and also there are participants who are working in various sections of admin, like hospital administration and quality systems. Policy contributors, like there are many participants who are working at the university levels and drafting the policies for future generation of say 5 to 10 years of transition, and how that transition can be focused on the policies. Public health expert, like many participants are reflecting from the public health domain, medical officers, the practitioners who are working in the community setup, rural setups, and digital health professionals. You are aware about many softwares. Now, there was a question in the audience asking about softwares for OSCE or NOSPI. So everyone is aware that this is needed. We cannot escape it. And that's the leading domain for future of IUC in the particular world, where this cannot be when you focus on the stage, this detail, because this has already been discussed in various presentations till now. But I'll just give you the stage wala approach. This is very important, and this you can take home. It is very easy to remember. There are only few steps we need to inculcate in the students. First is observation. Just ask students to observe everyday life. Just ask them to sit quietly and observe how the adjacent peer is working, or how the teacher is behaving, or maybe observe the particular Prakriti-based parameters. Question them, then investigate, then design, then validate, and then apply. These are the simple steps. I'll give you one illustration with the basic, ancient astronomical equipment, which is Jantar Mantar. We are all aware about it, and with the recent developments, many are talking about Jantar Mantar. So I thought of taking this as an example, where we can use this and how that particular instrument was developed. Basically, it started with observation. They identified a real life problem. And in the 17th century, you can imagine the period there. And the ancient astronomers observed that there are inaccuracies in current calculation, celestial calculation. So with the existing instruments, so can we develop something which is a highly validated tool? And then the Maharaja Savai Jai Singh too, he questioned why astronomical predictions are different between available tables. Everybody has their own set of astronomical tables. So he tried to inculcate that critical thinking in the team. And he said, okay, investigate, gather evidence, go everywhere, go to Indian scientists, Persian, Islamic, European astronomical text, just gather the evidence, investigate what is happening. And then they developed a solution that, okay, we have to have a massive set of instruments like Samrat Yantra, Jay Prakash Yantra, so that we can improve the measurement accuracy. And they repeated those observations. They don't only develop it. They don't only stop there. They tried to validate that. Okay, let me just do it again and again and repeat my observation again and again so that I can see whether they're accurate or not. Then Jantar Mantar becomes a scientific observatory, and they help others to come forward and check the astronomical details. Calendar development happened. So ultimately a problem was solved, but they didn't stop there. They actually think about the societal impact. They developed, they improvised the knowledge, navigation, calendars, and ultimately the scientific heritage. And if you happen to visit the Jantar Mantar anywhere in India, there are 13 such spots where you can visit. But particularly if I'm taking this example from Delhi, there are many yantras, sub-yantras which are developed, and they're arranged in a particular way so that astronomical calculation can happen. So again, I'm coming back to those 5 steps. Observe. What is the current problem around you? Question that problem. Can I solve that problem? What are the variables in the problem? Do I have the infrastructure in hand? Do I have the knowledge in hand? And then maybe investigate, okay, what is happening anywhere else? Maybe in other country, maybe in other state, maybe in other population, what is happening? And then design your framework, design a solution around that and then try to validate and apply again and again so that you solve a problem. Ultimately, research is about just solving a problem. It could be just sanitation of water, it could be just identifying a virus, or it could be just identifying a disease management. It's all about research when it comes to the any problem, day-to-day problem, or many multi-million problem like COVID. So how to map those competencies to program outcomes? That is what we are talking through this whole FDP. These program outcomes, yesterday Dr. Katti sir mentioned that program outcomes are not there directly in the domain, but the PG program outcomes will be released in a user manual for PG curriculum. I have put it across because I was fortunate enough to be a part of PG curriculum committee as a consultant expert. So I got this access to POs, and I'm just trying to put it across the UG POs. If you see the UG POs right now, I don't want to go in the detail. Everybody's aware about it. See, when you're talking about Miller's pyramid, there are only 4 steps: knowing how, showing how, and doing it. So these 4 steps are getting transferred from a UG mindset to a PG mindset. Okay, so UG mindset is like a vast, the radius of work is more. So they want to demonstrate comprehensive knowledge, apply those 3 sutra concepts, then maybe the skills related to the integration. Sometimes they will demonstrate holistic, unique assessment skills, ultimately practice their clinical skills under supervised or non-supervised way, and ultimately be an independent practitioner. So that is the limitation or the scope of the UG program. When it comes that a Ayurvedic physician is developed, but Ayurvedic physician is doing everything possible, like a general Ayurveda physician, where he has knowledge and capabilities to apply everything. With a limited scope, that could be a possibility because he has knowledge of everything, but the scope is slightly limited. And now you have to demonstrate academic, experimental, practical, and clinical decision making together in the PG set. So in UG, it was a vast canvas. Okay, a UG student can do anything. UG student can think about clinical practice, they can think about public health, they can think about being independent researchers. Everything is possible. But what happens to PG? PG needs to sit down and select a scope, and then they go deeper into it. And then they try to, think, I'm a Kriya Sharir expert, what I'll do in Kriya Sharir. I'm a Swastha expert, what I'll do in public health. So the vision becomes in depth on to the point, and then they start integrating that Ayurvedic knowledge with scientific advances in that particular chosen specialty. So always remember, our PG products, I would say, the students coming from the college are specialized. Like we say, the dentist, orthodontist are there, or pediatric surgeons are there. Specialist in particular section. Now everything is super specialized. Are our PG students super specialized? Are we a PG graduate for diet? Are we referring our students visa or maybe some skin elements? Are we referring our patients to certain cross faculties with
Ma'am, your voice is breaking. Hello?
to tell
Hello?
them that they are expert?
हेलो प्रियंका मैम,
Yes, sir.
मैम आपका आवाज बीच बीच में ब्रेक हो रहा है, तो आप थोड़ा सा वाईफाई का नेटवर्क का ध्यान दीजिए. ओके.
Is it okay?
Now okay.
Okay, better. Yeah, thank you. So I'll just tell you one more illustration that even today, many patients ask that, is there any toxicological advances in Ayurveda? Is there any social programs in Ayurveda? Is there any community-based programs? Because they're not aware about the super specialty. Our student, even if they are super specialized, they generally go to a fixed set of practice and they try to do the same thing, reinventing the same wheel. So we don't want to treat our students like that anymore. We have to tell them that how their skills can actually demonstrate various social solutions, and maybe in terms of surgical, experimental, clinical, or research-based practices. Same thing happens with the course learning outcome. When it comes to the PG, you can see, I have just highlighted those words which are very much important in PG thinking. Decision making. Now they cannot call to a senior, they cannot call to their teacher that what should I do? They are themselves the experts. They have to take the decision based on the literature available, based on the evidences available. So they have to critically understand and evaluate the scientific literature. That's the minimum essential thing for them. They cannot live without it. In the era where new viruses are coming, new bacteria are coming, new clinical gaps are getting developed, we have to be updated on our toes and we have to keep on learning every day. So prepare and disseminate the research finding. What is happening in the current research scenario? They also need to effectively present the findings to the patient. Nowadays, as everybody is aware, patients are more, having that inquiry mindset, and they keep on searching on the Google. They keep on asking AIs. And what is the solution? The treatment plans are already being made by AI. So what new can be given to the patient? How we can give something which is not there across any media? How we can utilize that information technology and apply those advanced instrumentation? Are we using certain instrumentation which we learned in our PG courses in our clinical practice today? That's the question to ponder. And I'm just keeping it with you. So again, I'm coming back to BMS to postgraduate transition. Again, you see with the dimension. As we learned with the Miller's pyramid, now you think about the dimension. And it is also talking about clinical skills, decision-making, research, and overall professional role. I'll give you one example. And if you agree, please put a yes mark in the chat box. Many a times, you might feel that there is a patient who in the past have some bad experience with certain Ayurvedic treatment or Ayurvedic, maybe some medicine. And they all the way stop taking Ayurvedic medicine or Ayush, particularly medicines. And they try to just shift to the pathy. They don't think that let me have a second opinion. Same thing if you think with terms with the medical sciences right now. If one cardiologist says, okay, this needs to be done, he thinks that let me try a second cardiologist. One orthopedic surgeon asked him to go for a surgery. Patient thinks, let me try some other opinion, let me try some other guidance. But when it comes to Ayush, people still believe that one failed experience or one bad experience is totally shifting the course of their treatment. So that is our responsibility, our professional role here, to be not only just an entry-level Ayurveda physician, but we need to be a clinician, researcher, academician, and a leader who will get back that patient into the Ayush circle again with trust, with competencies, and with impact, with a solution-oriented impact. They should know that, yeah, this may happen. Maybe something was wrong in the earlier thing, and now it is reflected back. So, the patient should choose Ayurveda or Ayush again and again. They should not think that one failed experience or one bad experience should decide the fate of their next treatment. So particularly in PG mindset, we have to tell them. I always give this example with the complex evidence information that what happens after 10 years, today in 2026, there are patients who are having lung transplant. There are patients who are having liver transplant, kidney transplant. So how you are thinking in terms of Sharir there, if they are using some other implanted organ or implanted structure. In the cases where the pacemaker is there for 20 years, 40 years, how you are treating the Hriday as an organ, that change in the complexity of the disease understanding, the hetu, the nidan, and ultimately the chikitsa needs to be revised again and again because the patient is changing. We have to change accordingly, particularly in the PG setup. Now, how dissertation can be strengthened? Because dissertation is like a major task for their PG setups. And I'm just putting it again, dividing in 5 simple steps. First, generally what happens, a student selects a problem, they go through literature and they develop like that, and what new can be developed. So in the first phase, they are very much enthusiastic to learn something which is solving certain problems. So they develop these competencies in first 2 semester, I would say, critical thinking, problem solving, creativity, and innovation, because they know that dissertation is an integral part of their post-graduation. And again, it holds 40 marks in the exams. So they give very much weightage to this whole activity. They ultimately design and conduct the research. And during that process, maybe after the 3rd semester, during that process, they try to understand the information. They develop protocol, they undergo ethics committee presentation, they apply those methodology data, they collect, and the presentation of the data happens. They map the information. They plan and collaborate with other students or community setups with the data, analyze and interpret. Again, the critical thinking comes in the picture, standing the data and presenting it. So with our various universities are nowadays mentioning that publishing the data is important. Communicating the research findings is important. So student nowadays is very well versed with the writing of the dissertation, publication of the papers, presenting at conferences. They are ultimately developing scientific communication. How I can deliver my idea to the people, how I can talk about my results. So ultimately, they are working on academic writing and presentation together. In a way, it develops leadership qualities, in a way, it develops communication skills. And then when they become, when they pass out and become a practitioner or a researcher, they sit in the clinic and try to translate that evidence into practice. They think that, okay, I worked with this drug and it was very much effective in certain condition. Let me try that again in this setup. Or my fellow student, my fellow friend was working on so-and-so topic. Let me try that composition. So what they are doing now is translating that evidence into practice. So then it comes to the public health, like sir was earlier mentioning about public health competencies and how those competencies can be developed in students. And when it comes to the evidence-based, it is nothing but collecting all the data and practicing it together with the evidence-based competencies. They are the same competencies, but in a cluster of 2 or 3 together. Like, for example, I want to work in a public health problem. Particularly, I'm giving example of obesity. So in obesity, I need to have a competency, not only for a communication to the patient, but I need to have a communication which will give me a behavioral change in the patient. I cannot just say that stop so and so or have so and so. I have to make sure that the behavior of the patient is changing. And ultimately, I am trying to combat obesity. So behavioral change is a very important competency. It is the next level of communication. Innovation. Many patients are already tried and testing the available solutions and they are not getting any relief. So can we innovate so that the patient is continuing or sustaining the whole line of treatment for say 1 month, 3 months, 6 months, or a year together? And ultimately, can we address this issue on a larger platform in public health? Suppose I want to add certain medicines in a public national program, public health national programs, any national program, non-communicable diseases or certain national programs related to children. I need to produce a data, I need to produce an evidence which is acceptable to the scientific vigor, and then they will say that, okay, this medicine is useful, let me have it in the public health. So ultimately, the evidence-based competencies are related to the cluster of 2 and 3 competencies together, so that the public health problem gets addressed. Okay, so we have to think that only one competency is not enough. Sometimes there is a group of competencies which work together. And ultimately, you see, I have 10 areas to cover. So I'm trying to just probe that inquiry in your mind so that you can go back and learn more about it in terms of what our students are doing and how we can actually direct them to the effective community. So when it comes to the ethics and responsible conduct, the competency of ethical behavior comes in the picture, not or just publishing the data. But I have tried to put this ethics into 3 different sets. The first set talks about ethics in conducting the actual research. So how the student is selecting their subject, maybe animal subject or human subjects. So are they aware about the basics like consent, risk, and benefit ratio, the privacy structures, reviews from IRB, IC, and ultimately all the approvals? Are they aware about it? Are they having that faith in their data? Are they having that integrity with the data? That results must be reported honestly. If I have a eligibility criteria, inclusion criteria as 9.5 hemoglobin, and if my patient's hemoglobin comes as 9, my students tries to think that, can I change it? 0.5 kya ho jata hai? So that 0.5 is also important. So whether they are thinking that in terms of their eligibility, whether they are thinking that in terms of exclusions or dropouts, or maybe data presentation, alterations, manipulation, what are their thoughts? We have to start from there. We have to tell them that negative finding is also welcome in research. It is not necessary that every time you get a positive result. So data integrity is one of the very important ethics in research. Conflict of interest. What happens sometimes that there are financial or personal affiliations, and that can improve or apply or influence the research. So we have to understand, are we taking any financial assistance? Are we taking any affiliation from any institute, or where we are actually working? We have to be clear on the conflict of interest. And if there is any funding involved, if there is any collaboration involved, are we declaring that on a particular disclosure statement or not? That is also very important in conducting the research, so that proper justified disclosure is given to everyone who are involved in the research. The second set of the ethics talks about communicating of the research. Like I mentioned earlier, publication, so plagiarism check, attributions, they need to know that those ideas are other ideas. Those texts are from somebody else's book. Citing and with proper attribution is very important. In the era of copy pasting and getting everything ready-made from the ChatGPT, or getting everything exported to a AI tools or a software, it's very easy to have this falsified authorship. So we have to tell our students that the idea must be respected for others. We should not take their ideas and claim at ours. So authorship criteria must be properly reflected in the contributions. Ghost authorship, gift authorships, you all are aware about these structures. So are we pre-registering the settings, pre-registering or reporting the settings to the competent authority? Like we have a CTRI platform in India. Are we registering our trial? And I would again like to motivate all the participants and the students who are listening to this presentation. Any university right now, but that CTRI gives you a platform where a patient can also see your trial, expert can also see your trial. So in a way, it gives you a good visibility for the research. And ultimately, when you are publishing, in a good journal, CTRI registration helps because now prospective trials are only registered. So we have to have that registration in place before you start the research. The third set of ethics is related to publishing ultimately. Like what happens is generally students, they submit parallelly to two or three journals, that let me see where I get selected and then I can just go ahead with that particular publication. But dual submissions or the original submission should not be repeated with other manuscripts. Always have one journal, one manuscript approach. If that manuscripts get rejected to particular journal, you can revise, redevelop, and resubmit to maybe some other journal once the first outcome is declared. Otherwise, do not parallelly submit to the multiple journals. Peer review integrity. Just because the manuscripts are from our college, we should not treat them fairly. We should also maintain that particular interest of the topic, that whether the review is happening, whether the editors are properly reviewing the article or not. We have to inform our students that multiple review notes are important when it comes to the publication of the data. And post-publication correction. There could be some post-publication communication from the journal or maybe from readers. Are we trying to oblige that particular correction? So that is also important ethics approach. When it comes to the assessment, earlier speaker also mentioned that assessment is very important when we are teaching something. Ultimately, it is all.
Madam, your voice is breaking. Hello? Hello?
To keep on checking.
Hello? Madam,
Yes.
your
Yes, sir.
voice is breaking.
Just a minute. My internet is there.
Okay, but something is not wrong. Okay. Now it is clear now. Hello?
Okay. Okay.
Madam, as per schedule, we have lost 5 minutes.
Yes. So when it comes to the key assessment method, we have to work on these 4 stages. It's very important that, and for every step, we have a 3-question approach. So this is very simple to execute. All the guides here can take benefit of this, that how we can check the performance. Can student explain why the research was done? Can student explain the results in simple words? And has a student written the dissertation independently with your guidance? So, these are performance-based rubrics. Similarly, self-assessment can be done. Supervisor evaluation happens at the examination level also. But these 4 steps can happen at every semester. And at every semester, you can see what kind of skills they are developing, what kind of competencies they are developing. Ultimately, I would say that when it comes to the exact litmus paper test, that whether that student has achieved those competencies or not, are you going to the student 10 years after this and with that confidence that this student will treat me well, with that teacher's confidence that that student has gained that competency? So that's the ultimate test for any guru to perform on student. Faculty as research mentors, the importance of guru, and even Alam Prabhu Huda sir mentioned today example of honorable that the role of guru is integral. The guru plays important role in terms of inculcating those values across generations. Many scientists, many researchers are already gurus in the various universities, right from Albert Einstein to Amartya Sen. They are already teaching, they are continuously transiting that knowledge to the next generation. Which we adopted. First is don't give direct answers. Try to ask questions to the students. Don't chase a thesis, just try to build the competence. And don't create followers, try to make them independent researchers. So generally what happens is students try to mimic the teacher. They think that it's easier to get it done. But we need to also tell them that their unique perspective, their personality should get reflected in their work. And that is something which we need to do. We have to make them themselves more, so that that competency can come out more effectively. When it comes to the digital technologies and AI, I would just say that when it comes to the balance of both, this nowadays the machine learning and AI tools are so many that there is a chance that the machine is also getting confused because of the similarity of the data sets, because of the similarity of the findings. They are not in a position to separate the relevant data with the irrelevant data. So we have to work with being original and responsible with our ideas, critical evaluation, ethics, accountability, and trust. We need to work on that. And maybe AI assistance can come handy when you have to help with searches, we have to help with language or summaries or structure the whole routine task. Then the AI can be handy. When it comes to the researcher in healthcare, AI can be really helpful in the mistake or error management, that a same mistake or same error cannot be repeated. The validity and reliability of the data, or the scales or the questionnaires they use, standard scales of measurement, like, that validation can happen. Again, we have to use real powers of AI and ML so that we get that sorting kind of a tool in hand. The most important translational research I would like to put here, which is a very important competency, how India demonstrated that. We developed these competencies in COVID, and we actually demonstrated those competencies to the world. Even in Ayush, there is a very interesting literature published, which is based on research and development initiatives of Ministry of Ayush for COVID-19, with many protocols and SOPs in place. So India developed those competencies and demonstrated with a problem-solving attitude, where they not only solve the problem, but they manage that information, communicated across the world, collaborated, and ultimately it was like a vaccine Maitri initiative, where the global help was generated from India. So I would just highlight one important. If your student or yourself need to introduce yourself without mentioning your name, designation, or authority, how will you do that? So that might be just the explanation of the competency. The true competency is the seamless integration of knowledge, skills, and attitude into work. The actual work should demonstrate that all these three are there with that artist, with that trainer, with that student, with that learner. So ultimately, it becomes your timeless signature, creating an enduring impact even after you're gone. So thank you so much, NCISM, for giving me an opportunity to share my views. This presentation is available on the YouTube also, and learn through it. If there are any questions, I'm free to take those questions. Over to you, Kiran, sir.
Yes, thank you, ma'am. Thank you very much, madam, for your excellent presentation, for giving the clear message on OBDC and ethics. Now we have one question on chat box. Can I ask?
Yeah, please.
Question is that we find one question, that is how were these domains correlate. Dr. Shri Vaidya asked for the source, basically, where these domains are find or correlate. Question is available in our chat box. At 4 p.m., 4.4, 4 p.m., 4 minutes. Hello, ma'am. Actually, madam, I have some bad network sometimes. Okay, no problem. We will ask madam and Tanmay to our participant. So now we are at the end of today's session. With this, we have successfully completed all the academic session scheduled for today. I sincerely thanks all our respected resource person, that is Dr. Harti sir, then Dr. Gujarati sir, Dr. Joshi madam, then our moderator Dr. Morana sir, distinguished dignitaries, and all the participants for their participation. I also express my gratitude to the Dr. Manisha Kothekar ma'am, Honorable Chairman, NCISM, Dr. Alam Prabhu sir, President, Board of Ayurveda, Dr. Diviti sir, Dr. Vashne sir, Rehma ma'am, and my fellow coordinators, Dr. Patil sir and Dr. Bagdi sir, and entire NCISM team for their continuous guidance and support. Thank you all once again. We will meet tomorrow again at 2 p.m. for our third day sessions of this faculty development program. With the permission of our respected dignitaries, I now conclude today's program. Thank you. Have a wonderful day. Thank you. Thank you, one and all.
Thank you.
Thank you, sir.
Thank you.
Congratulations.
Thank you.
Patil sir wants to communicate something.
Selective